Recessed jaw.
Okay.
Is that
You hear Robin syndrome, where they don't have much of a mandible?
Right.
Is that Malampati?
Yep. Okay, so
The difficult Malampati is what you.
the Malampati is a great tool, but to use the Malampati correctly, your patient has to be sitting up. How often do you have a patient you're going to intubate that's sitting up?
With their mouth wide open, you can look down now.
So what else? Remember, if you can't get a good mask seal, you would be very hesitant to RSI somebody.
Short
correct?
neck with
Facial
obesity.
trauma.
Facial trauma. Okay. So I've got a little video, just to give you something to think about. When we go out to respond to calls, we don't always see. Not every patient we respond to is messed up, or a lot of patients we can use a BVM on. But I've got a video that shows the 5 most messed up faces in the world. So
Cool.
let me turn off the lights. And just as you're watching it, it's really informative, but as you're watching it, think about how would you manage that person's airway.
That looks really vascular too.
Is this for?
So no, those are not typical presentations that you're gonna see when you have to encounter a difficult airway. How would you like to have to manage one of those airways? Except the last guy, that might be pretty simple.
Yeah, stick it through
I
the hole.
have worked on that very same presentation, actually more of the teeth even were exposed. He was a regular at the clinic where I worked right out of college. And he lived like that for years, but the maintenance was a lot. You had to, you know, hydrate the mucosa, the nasal mucosa all the time, the eyes. Kept dressings over it most of the rest of the time. But he came in almost every day to get suctioned and get clean dressing. But he walked around like that for years. This was, what, 1985?
Wow. But if you think about the first guy that had the 12-pound facial tumor, if he called you for shortness of breath, what in the world are you going to do with him? Now those are not, of course, typical presentations that we see a whole lot of, but if you were to have that situation, or even somebody, let's just think about somebody who has just some kind of facial tumor. It doesn't even have to be something that large. But anything that will inhibit getting a good mask seal with your BBM is going to be a problem. Because you cannot RSI if you can't get a mask seal. In case you were not unable to intubate, how then are you going to ventilate your patient? And a couple of those, you know, there's really no way to even do a surgical airway. You can't displace all that tissue. So I just hope in my career that I don't have to do anything like that. That'll be fun. All right. All right, we're going to talk about capnography. So tell me, when do you use capnography?
I speak of you all the time.
What do you use it for?
Make sure they're respirating, they're getting good respirations, they're exchanging gases.
Okay. Do you use that when you've intubated somebody, you have an airway in place, or do you use side stream connectors? Both. So what is entitled CO2? What does that even mean?
And measures the level.
Measure up CO2 in there.
Measures the level of expired CO2. It's a snapshot in time, and it will bring other changes the body tries to maintain homeostasis. So you can monitor your patient's ventilation perfusion just with this simple tool. It has become a standard of care, not only in North Carolina, but for National Registry. It's a standard of care. Anybody that's not using it is putting themselves at a liability. It's not that crazy expensive. Go ahead.
And this is part of how transition came about, is all the national state training officers got together in like 2000, and each state talked about the advanced things that they were doing in their state, and guess what state was doing more CO2 monitoring than any other state? We were. Okay? We were ahead on CO2 monitoring. We were ahead on 12 leads of the whole rest of the nation. So this is how transition came to be, is that all the states agreed that all these different components that are technically critical care information would be brought into the entry-level paramedic training. And so for anybody who finished school prior to 2013, state level and national registry level, states also said everybody out there that's been out there longer than before 2013 has to have a transition course. So National Registry is making it happen at National Registry level first, but the state will also, 2 years from now, 3 years from now, will also say, okay, you have to have a transition course. You will have already had yours if you're, you know, even if you are not going to do National Registry, you're just here for North Carolina hours. Yeah.
So this will count for the state?
This is supposed to count for the state one, because the state told us, okay, here's the things we already do in North Carolina. You don't have to do those for transition because we've been doing them 10 years. Here's the things in North Carolina that we don't do to catch us up to the rest of the nation. So all that's covered in this deal, so package deal.
Okay. Entitled CO2 is monitoring of non-invasive, method of determining carbon dioxide levels in intubated and non-intubated patients, depending on whether or not you're using mainstream capnography, which attaches to your advanced airway, or side stream capnography from a nasal cannula. Using infrared technology, we monitor exhale breath to determine CO2 levels numerically and by waveform. The difference between capnography and capnometry: capnography is the actual waveform that you see on your monitor, and your capnometry is your numbers. And there are some monitors out there that only do capnometry, but if you had the choice, which one would you prefer to have?
Waveform.
Waveform, absolutely. And total CO2 is directly related to the ventilation status of the patient, as opposed to your SaO2, which is your oxygenation of the patient. So while your pulse ox is a great trending tool, it's not minute by minute snapshot in time, so to speak. It's not an immediate monitor of what's going on in the patient's VQ match right now. Capnography can be used to verify endotracheal tube placement and monitor its position, assess ventilation and treatments, and to evaluate resuscitative efforts during CPR. That being said, and as Glenn was talking about, it is the national standard, it is the golden standard to use capnography when you have an advanced airway in place. You know immediately if your tube is in the correct place. Now, we talked the other day about giving 6 breaths before using colorimetric devices, because you may have, somebody just been drinking a Coke and they have carbon in their stomach, and you intubate the esophagus, you're going to get a CO2 reading. Even with capnography, it's okay to put your capnography on immediately, but if you want to give it a good 6 breaths before you actually start looking at your waveform to ensure that you truly are in the trachea. As far as resuscitative efforts during CPR, if you notice, if you have your patient intubated or have an advanced airway in place and you're monitoring your end-tidal CO2 levels during CPR, you will see, if you get return of spontaneous circulation, you will see your waveform and your capnometry readings jump. You'll have a sudden jump, and it's an indication that the patient's body is perfusing now. That being said, if you are monitoring capnography and you fail to get your end-tidal CO2 above 10, any number that is sustained below 10, there will never be a return of spontaneous circulation. So it's a criteria for ceasing efforts. Just a review of the pulmonary anatomy and physiology. Your upper airway, your lower airway, during inspiration, upper airway via the nose where it's warmed and filtered and humidified. The inspired air flows to the trachea and bronchial tree, and there's the pulmonary alveoli where oxygen diffuses across the alveolar capillary membrane into the blood. When would there be a problem with diffusing into the bloodstream? Think about your alveoli.
Lack of surfactant.
Lack of surfactant, that's a great answer.
Or that mucus condition.
Atelectasis,
Yeah.
where it gets sticky in the collapsing term. Could be from pneumonia. If you don't have, if your alveoli are not able to expand, COPD. COPD is not that they just have air trapping. That's more of a mechanical problem. All right, so the heart pumps freshly oxygenated blood through the body to the cells where oxygen is consumed. That's metabolism, and carbon dioxide, produced as a byproduct, diffuses out of the cells into the vascular system. This is what your end-tidal CO2 is reading, your expired CO2, and it reads it by infrared technology. Carbon dioxide-rich blood is pumped through the pulmonary capillary bed, where the carbon dioxide diffuses across the alveolar capillary membrane and is exhaled via the nose or the mouth. Again, if you have problems with your alveoli, you're not going to have good gas exchange. Carbon dioxide itself is colorless, odorless gas. Concentration in room air is 0.03%. It is produced by cell metabolism. Transported from the cell in 3 forms: 65% as bicarb following conversion, 25% is bound to blood proteins and hemoglobin, and 10% in a plasma solution. And your PaCO2 reflects the plasma solution when you have that blood draw. So, we used to use the colorimetric method. Then a problem with that is that paper becomes moist very quickly and is no longer accurate. And people were using it immediately once they intubated, which is great unless you intubate in the esophagus and use your 6 breaths up, and then all of a sudden your paper's not telling you the correct information. So it was not foolproof at all. Once we started using capnography and you have your waveform, you have what's the word I'm looking for? Undeniable proof that you are indeed in the trachea and you're perfusing your patient. CO2 sensors may be mainstream, located directly on the patient's endotracheal tube, or side stream remote from the patient. Side stream, typically you'll see that in a nasal cannula form. They do make them on a non-rebreather as well, but they're kind of expensive and a lot of places don't bother to carry that. Mainstream sampling occurs at the airway of the intubated patient and is not intended for use in non-intubated patients. If you have a patient that you're using side stream capnography on and they're not breathing through their nose, they're breathing in and out of their mouth, is your side stream going to work, your cannula going to work very well? Not so much, but what can you do with it?
Put it in their mouth.
Put it in the mouth. Side stream capnography, the exhaled CO2 is aspirated via ET2 cannula or mask through a 5 to 10 foot long sampling tube connected to the instrument for analysis. It's intended for the non-intubated patient, and both technologies calculate the CO2 value in waveform. Again, the side stream capnography is not as spot on as, because there's so many factors come into play as the mainstream. However, again, if you want to put it in down across the patient's mouth, if they're a mouth breather, or even if you take and if your patient needs more oxygen than a nasal cannula, you can put nasal cannula on them and then put a mask over top, a non-rebreather mask over top. Let's see, the Zoll monitors. What monitors do you all carry?
Relax.
Zolls? LifePaks? Anybody have a Philips?
We had Zoll here, we had life packs back in the morning, so.
My service has Zolls, but they're the old chop block Zolls.
They carried both, in the ES. The Zolls were the backup because we did the dual shock carrying cardiac arrest. So we put both monitors.
That's good.
Very.
All right, so your end-tidal CO2 monitoring is continuous, and it shows changes in ventilator status immediately. Whereas your SaO2 monitoring is also continuous, but relies on trending, because oxygen content in the blood can maintain for several minutes after apnea, especially with pre-oxygenation. So this is just a waveform here. Here's your EKG. Here's your SpO2. And down here's your capnography. There's not any waveform there at the moment, but that's where you would print it out and look at it. So the problem with your pulse ox, let's just talk about that a minute. A great trending tool, yes, but when would it be unreliable?
Cold extremities.
Carbon monoxide, cold extremities,
Fingernail polish.
nail polish.
Sometimes light will bother it too.
Yes.
It's covered.
Yes. So it's not the most reliable tool. It's a great training tool, but not. Would you ever look at your pulse ox and say, oh, well, they're satting at 92%, I should put them on oxygen? I would hope you wouldn't rely on your little machine to tell you your patient needs oxygen. You should look at your patient and determine if they need oxygen. Or, well, your patient's sitting there short of breath, but their pulse ox is reading 100%. You're going to deny them oxygen because your pulse ox has 100%. No, so we treat our patient, not our equipment. Your normal values for your end-tidal CO2, normal is 35 and 45. Where do you remember seeing those numbers?
Blood gas.
On your blood gases, yeah. 35 to 45, if it is less than 35, it's an indication of hyperventilation, respiratory alkalosis. If it is greater than 45 millimeters of mercury, it's an indication of hypoventilation, respiratory acidosis. And then, of course, dependent on three variables, your CO2 production, delivery of blood to the lungs, and alveolar ventilation. The 35 to 45 numbers, you see commonly, you'll see that if you remember what with your blood gases we talked about yesterday, your pH level was, your normal was 7.35 to 7.45, your CO2, 35 to 45. With your increased CO2, you got the decreased CO2 clearance, decreased central drive, muscle weakness, diffusion problems. If you have an increased CO2 production, you're looking for fever, burns, hypothyroidism, seizures, bicarb, ROSC, release of a tourniquet or reperfusion. We talked about ROSC just a minute ago, that you will see a jump in your capnography reading when you get return to spontaneous circulation, because we do well enough, we do well enough perfusing the patient's body when we're doing compressions, but you can't really do as well as the body can do for itself. So there's a jump in perfusion there that you get to see. If you decreased end-tidal CO2, you have an increased CO2 clearance, that can be from hyperventilation, decreased CO2 production, hypothermia, sedation, paralysis, decreased delivery to the lungs from lack of cardiac output, a VQ mismatch, ventilating non-perfused lungs, maybe from pulmonary edema, atelectasis, pneumonia, things like that. Your ventilation perfusion ratio, so your V to Q, and I don't know why they chose Q for that, that doesn't make sense, but VQ mismatch is ventilation perfusion ratio. Effective pulmonary gas exchange depends on your balanced VQ. So if you have alveolar dead space from atelectasis, pneumonia, pulmonary edema, etc., your ventilation is greater than your perfusion, and that's a decreased CO2 content. If you have shunting, as in the blood bypasses the alveoli without picking up oxygen, your ventilation is less than your perfusion, and you have an increased CO2 content. So you want to think of it like this. This is your ventilation, this is your perfusion. They match, right? Well, if one of them gets out of balance, it's not a match anymore, is it? So you want to have a good homeostatic system going on with your ventilation and perfusion. Here's just a chart that shows your venous blood, your arterial blood, the pathways, perfusion without ventilation, ventilation with perfusion, what the normal is. I can print that off if you guys want to have a copy of that. Any of the charts or anything in here, I can get a copy for you. So your VQ mismatch, you have inadequate ventilation, perfusion, or both. And there are three types. Your physiological shunt. So here's what's happening. Your ventilation is is less than your perfusion because you have blood bypassing the alveoli, severe hypoxia with greater than 20% bypass blood, a result of pneumonia, atelectasis, possibly a tumor or a mucus plug. So how do we fix these things? How do we get a better VQ match?
You address the underlying problem.
Address the underlying problem, absolutely. So a lot of this stuff is not necessarily pre-hospital, it's the big picture, it's the long-term patient care. Can you fix pneumonia pre-hospital? No, you can treat some symptoms, you can take care of their fever, you can give them some oxygen, perhaps some fluids, something to start the process, but they really need to be on antibiotics, something to clear up the pneumonia itself. Can you fix atelectasis pre-hospital? That you can. Increase peak. So what about, there's nothing we can do obviously pre-hospital for a tumor. What about a mucus plug?
Saline?
I'm sorry?
Saline?
Saline, it just depends. If it's somebody that is not intubated
Okay.
or doesn't have a stoma or something, but you could, along that mindset, you could give nebulized saline. You could do it that way. Help loosen them up.
What about humidified air?
Yeah, that's nebulized saline.
Yeah.
It's humidified oxygen. Alveolar dead space. You have your ventilation is greater than your perfusion. Your inadequate perfusion exists. Can be a result of pulmonary embolus, cardiogenic shock, mechanical ventilation with increased tidal volumes. Are those things we can fix pre-hospital? Can we do anything about a pulmonary embolism pre-hospital? We can be supportive and treat the symptoms, shortness of breath, we're going to give oxygen, etc. But other than that, they really need to be in the hospital. What about cardiogenic shock? Do we treat shock pre-hospital? Yeah, absolutely. So, but again, we're treating the symptoms of it. Right. Mechanical ventilation with increased tidal volumes. Can you fix that? Yeah. That you can fix, absolutely. If you have both a decrease in your perfusion and your ventilation, it's most likely caused by a pneumothorax or ARDS. If you don't have lung expansion at all from a pneumothorax, you're obviously not going to have good ventilation or perfusion. ARDS, adult respiratory distress syndrome, most commonly the lungs become really stiff and full. There's not a whole lot of any lung expansion at all. You have to greatly increase your tidal volume and your peak, et cetera, to try to manage that. And ARDS patients, you don't typically see a whole lot pre-hospital. That's more of a going from point A to point B situation, and they should already be on a vent. So here's an example of what your normal perfusion ventilation looks like. Over here you have a low VQ from your arterial ventilation. So if this is your alveoli here, and you can see where it's collapsed, you're obviously not going to have a whole lot of gas exchange. Down here, the shunt is very low, so you're bypassing it. You can see there that you're not going to have a whole lot of gas exchange. And your high VQ over here, you have alveolar dead space, so it's impaired perfusion. More air, less blood. Your ventilation is greater than your perfusion. Equal air and blood, that's a good thing. That's equal, it's a VQ match. And more blood, less air, your ventilation is less than your perfusion. That makes everything pretty much very simple right here. So here's your normal Untitled Chapter. So on your uptake right here is your expiration, your plateau, and then your inspiration. So this is what you're measuring right here. This is the actual number that we're looking for. This is what a good waveform is supposed to look like. It's nice, it's squared, it's even. You have good, your alpha angle here is really good, your beta angle here is really good. So that's what we want our capnography to look like. A to B describes the respiratory baseline and is measured the CO2-free gas in the dead space of the airways. B to C is known as the expiratory upstroke, and that's where you're breathing out, where the alveoli air mixes with dead space air. So that's as you're expiring, and then you're going to get your plateau reading here, the C to D expiratory plateau, and that's the exhalation of most of your alveolar gas, and it should be pretty much a straight line across. Point D is the level at which the end of a normal exhale breath, and that's where we want to see our 35 to 45. D to E is your inspiration, inhalation of the CO2-free gas, and rapid return of waveform to baseline. This is not measuring anything when you're taking your breath in, correct? As you can see here, you've got a good, strong expiratory upstroke, a strong alpha angle, a good plateau, strong beta angle, your drop for inspiration. Then it continues on into the next one. That is what we want to see. Changes in the capnogram or Untitled level reflect a change in metabolism, circulation, equipment function, or ventilation. Untitled CO2 can be reliably used to determine without ABGs if your PA CO2 in patient is the normal ventilation perfusion. Again, we're looking at 35 to 45 preferably. And it's typically 1 to 5 millimeters of mercury less than your PA CO2. So your numbers should match. When you get your ABG and you have your patient on capnography, they should be pretty close together. All right, so your non-intubated patients, it'd be beneficial to use Untitled in certain situations. Asthma and COPD patients, CHF and pulmonary edema patients, if you suspect your patient has a PE, head injury. And this is just, what? Those are expensive. How often do you have somebody who runs the budget talking about, did you really need to use that? But again, it's a golden standard, and if you were to fail to use equipment that is available to you on your truck, and for whatever reason ends up going to court, who's going to be responsible? You are. Because that lawyer's going to sit there and say, you have this equipment on your truck available for you to use. Why didn't you use it? And sending up there saying, well, you know, they frown on us using it because it's expensive. So you just decided that a piece of equipment was more important than somebody's life. That's not a good thing. So with your asthma and COPD, you can provide information on the ventilatory status of the patient, which combined with your other assessments can guide your treatment. So if you knew that you had a ventilation perfusion mismatch with your asthma or your COPD patient, and they're not overly complaining of shortness of breath, would it give you an indication that maybe just oxygen isn't enough, or maybe you need to consider a bronchodilator, or maybe you need to consider your glucocorticoid steroid or something along those lines? So it's not just based on your patient's complaint, it's based on their actual perfusion. Waveforms can indicate a need for bronchodilators, so your sharp fin waveform, you can see the normal there, and you can see when somebody's having an asthma attack. If you will note, the loss here of your angles, you have a really, really weak alpha angle, and when you're having an asthma attack, your inspiratory upstroke is not as strong, so they're having a hard time breathing. And yes, most commonly we can look at the patient, see that they're in distress, we can listen to lung sounds, but it's all about the big picture. So ventilation assistance intubation should be considered with severe dyspnea or respiratory acidosis. If your PaCO2 from your blood draw is greater than 55 millimeters of mercury, or your end-tidal CO2 is greater than 50 millimeters of mercury. Patient's got way too much carbon. Severe asthma attacks because they have that air trapping. They're getting air in, but they're not getting air out. So they're having, the mixes gets off balance, and with the alveoli just can't keep up. So would it be beneficial to your patients to take over their ventilation for them? If you could. All right. When would you consider intubating an asthma patient? When would you?
Yeah, albuterol treatments aren't working. Starting oxygen saturation is not improving at all.
Okay. Would you agree that you could technically, you could have 100% on your pulse ox in your patients in severe respiratory distress?
When they're no longer able to keep up.
When your patient starts to get tired, you don't want to wait till they're wore slap out and pass out, right?
Yeah, hurry.
You want to be aggressive about that. Severe asthma attacks may include pulsus paradoxus greater than 20 millimeters of mercury. Pulsus paradoxus, when they take an inspiration in, you lose your radial pulse, or you lose your, when you're listening to a blood pressure, you have a sudden drop. So greater than 20 millimeters of mercury. Also consider your altered level of consciousness in decision making. If they're hypoxic to the point they're becoming altered, you really want to think about being aggressive. 18% of ventilated asthma patients suffer attention pneumo. Again, they have air trapping, so putting a whole lot of air in there and not getting as much air out. I think I talked the first night about, or maybe it was yesterday, I don't remember, they were kind of blended together, about a friend of mine that decompressed an asthma patient. Not trauma, but she had so much air trapping that their interthoracic pressure got to be too much and she went into cardiac arrest. Well, if you had a patient, a trauma patient in that situation, had too much air in their chest, it's causing increased interthoracic pressure, you would decompress, right? Makes sense to me.
Did it work?
It did work. It did work with me. So here's your waveform for your emphysema patient. You see the abnormality here? The plateau is at the wrong angle, and also you have an uneven waveform. Your waveform should be maintained along a certain line, so they should match up. It should be, if you're reading over here at 40, and this jumps up here to 50, that's a problem. There's no bronchospasm in CHF and pulmonary edema. The values may be increased with hyperventilation or decreased with hyperventilation. With your PE, you could have a normal waveform but low numerical value. Why? A normal waveform is based a lot on expiratory, right?
You're not getting gas.
Because depending on where
They're just not getting gas exchange where?
we're past the blockage.
Past the blockage. So they can have great gas exchange at the alveolar level, but if it's not getting anywhere, what's their perfusion? Their tissue perfusion. Crap, right? So your angled C to D section, your plateau there, indicates alveolar dead space. But it looks like a normal waveform, right? And again, like it says here, look for other signs and symptoms. A patient with a pulmonary embolism, what do you expect to see from them? What do you expect?
Shortness of breath.
Shortness of breath, what else?
Chest pain, anxiety.
Chest pain, anxiety is the big key. You have that patient that just can't keep still, there's a problem. If you have a patient in pain and it's a result of some kind of muscular pain, do they wiggle around a whole lot? No, people in pain tend to keep still. However, if you have somebody that has pain as a result of ischemia, they don't keep still. They're trying to get away from it. They're trying to improve their status. If you have a patient with a head injury, CO2 is very useful in monitoring intubated head injured patients. If you have the patient with increasing intracranial pressure and you want to try to control that with controlled hyperventilation, would you agree that having end-tidal would be key on that? Where do you want to keep your end-tidal number targeted with a patient with increasing intracranial pressure? Ignore what that says. Our normal range is 35 to 45, correct? with you have a head injured patient and with increasing intracranial pressure, you want to try to keep your numeric value between 30 to 35. It needs to be just a little bit lower.
As well as BP?
Your blood pressure,
Okay.
actually, can we pause this a second? Sure. Yeah, this is not,
Okay.
all right. So hypothermia, you see, and here's hyperthermia. Why do you think your number is dropping? Think about your ventilation perfusion match there. Go back and look at the hypothermia.
Because you don't have enough time to collect more CO2, so it's dropping all this. If you're breathing fast enough.
You breathe faster when you get hot. So you're not, and you're exactly right, you're not building up your CO2. So it drops and drops and drops. It's the same thing with hyperventilation. I lost my train of thought there. Hyperventilation and hyperthermia. Here's hypoventilation. So you're going to see your CO2 number increasing. Why is that? Because you're not blowing off all the carbon. Could be air trapping. You're maintaining longer, so there's more carbon to be released when you do breathe out. All right. CO2 in the intubated patient is most often used to identify esophageal intubations or accidental extubations. Head and neck motion can cause ET movement of up to 5 centimeters. And you think about that, there's a reason that when you intubate somebody, it's recommended that you put a C-collar on, because you don't want that head and neck mobility, because that can displace your tube. If your waveforms or numeric values are absent or greatly diminished, you need to consider that your tube has been displaced or it's in the esophagus. Now this says don't rely on capnography alone to ensure intubation, but if you have a solid waveform capnography, continuous, are you in the trachea? Are you in the correct spot? You have to be. There's no other option. Because even if you had your esophageal intubation, even if you had some kind of carbon from Coke or whatever in the stomach, or beer or whatever it is, that's not going to last. So continuous waveform capnography is a guarantee that you're intubated in the correct place. Good waveform right there. Not so great waveform right there. Esophageal intubation, you could have very minimal carbon readings. That's not a good solid waveform at all. Here you go, carbonated beverages. And you will see there's a decrease. And eventually it will just go away. So you start at 38, 34, 30, 15, 17. And you didn't have a good solid waveform. You've got a loss of your beta angle entirely. You can see that is just... So this one says your values of less than 20 millimeters of mercury is an unsuccessful resuscitation. The number in most literature is 10. If you don't have capnography reading of 10, you are not going to be able to resuscitate your patient. If you have a low reading, but you have good CPR recovering heart, that number's going to spike. So let's say that you are maintaining your end-tidal around 24 during resuscitation. When that patient gets a return of spontaneous circulation, it's going to jump dramatically. And so you're going to be looking all of a sudden, now you've got an end-tidal of 40. And you can see here, this is what you were doing with CPR, and all of a sudden you've got a big jump. Successful defibrillation. So, and that's with good CPR, of course, because then you're going to start perfusing the heart again. So here you were, oops, hovering about 15, then defibrillation, good compressions, and then you had your spike. Because CO2 measures cardiac output, rescuer fatigue during CPR will show up as a decreased. So when your person doing chest compression starts to get tired and they're not doing really good solid deep compressions anymore, you'll see a drop. And this is where they're changing in rescuers, and then you've got your fresh person coming on. Can you see the difference here? We're at 10, here we're at about 25. Now it's recommended that you change rescuers every 2 minutes anyway, but there's science behind that. That's why, because you just get tired and you get lazy. If you have a right main stem intubation, numerical values and waveforms may or may not change, but your pulse ox will. Why?
So you're ventilating the lung?
Okay. Because the ventilation perfusion mismatch gets off. So yes, you still have the expired CO2, and it's showing from the one lung that there is good CO2 levels, but your pulse ox drops because you're only ventilating one lung. You don't have the gas exchange that you would with two. With a kinked ET tube, you have no alveolar plateau and very limited gas exchange, and you can see here that you have no alpha angle because this should come straight up and then come across for your plateau. Now your beta angle is still there and your intubatory phase is still there, but you can see where that would be a problem. So if you saw this waveform, it would give you an indication that you need to do what? Check your tube. The coare cleft is that little dip there. And what that is an indication of, that is an indication of diaphragmatic movement. When you paralyze somebody with your RSI drugs, paralytics happen in a orderly fashion. So the first thing to be paralyzed is the facial tissue, muscles, etc. And the last thing to be paralyzed is your diaphragm. It's the very last thing. But it's also, it goes in the opposite way when the paralytic is wearing off. So the first thing to become unparalyzed is the diaphragm. So the coare cleft there is spontaneous diaphragmatic movement. So when you see that, you know it's time to do what?
Give them more drugs.
Resedate your patient. Accurate and reliable in seizing patients, well, if there's no waveform, there's no chest wall movement, and obviously if you're not moving air at all, you're not going to have a waveform. Ineffectively ventilating a seizing patient, you're going to have a low waveform, a low internal CO2. They're breathing a lot of their CO2 off. And effectively ventilating them, you're going to have a normal waveform. That's common sense. Apnea, no waveform. The bronchospasm, that's your asthmatic patients where you see the shark fin waveform. Respiratory failure, if you have a patient whose waveform or capnometry readings are greater than 70 millimeters of mercury, so somebody with severe air tracking, etc., that's serious respiratory failure. So even if you were to determine this to be a side stream capnography, what do you want to immediately do? Secure an airway, ventilate your patient. I can print that chart off for you. More of it. More of it. Your diabetes and dehydration, your end-tidal CO2 tracks serum, bicarb, and degree of acidosis. So decreased end-tidal CO2 would indicate metabolic acidosis. It does help to distinguish DKA from NK-HHC or HHNK and dehydration. I'll print those off. Those are no fun to look at. Okay, sudden increase in end-tidal CO2 can be from, again, Ross, malignant hyperthermia. When do you see malignant hyperthermia? It's a result of what?
Rapid sequence induction.
It's a reaction to succinylcholine, okay? What is your first indication of malignant hyperthermia? If you did not know that your patient was going to be susceptible to it, and you RSI, and you use succinylcholine, what do you think your first sign and symptom is going to be?
Flushing?
Before that, before your patient ever gets a fever. The first thing you're going to see is a sudden rise in heart rate. So when your patient who you've intubated, so that you're maintaining their airway and ventilation for them, and all of a sudden you go from a heart rate of 80 to 120 sustained, there's a reason for that. And the next thing you're going to see is all of a sudden their body temperature is going to start climaxing, start rising. Is there a reversal agent for succinylcholine? Can you do anything about it?
It works so fast, though.
Okay,
There
There is.
but there is one,
the
but
problem
it's not.
is it's not pre-hospital.
Right.
It's not even in the ERs. The only place that you find it is in surgical sites. Because it's not just a draw. All right. So we've done this one. If you have a sudden decrease in your end tidal, but it does not drop to zero, you have a potential for a leak or obstruction in the system, maybe a partial disconnect from your vent, partial airway obstruction, secretions, so you could treat that easily. And high-dose epi can also cause a decrease. If you have a change in your baseline, the potential for a calibration error, mechanical failure, or water in the system. Need to check all your tubing, need to check your vent itself, check your monitor. If you had a continual exponential decrease, a very obvious slope downwards, you're looking at potential for a pulmonary embolism, perhaps your patient's going into cardiac arrest, sudden hypotension or hypovolemia, or severe hyperventilation. If you have that handy dandy first responder that's ventilating your patient at 50 times a minute, it's going to be a problem. If you have a gradual increase in your end tidal, it's possible you have a rise in body temperature, potential for hypoventilation, partial airway obstruction, or some kind of reactive airway disease. I have this strip back in 1983. Alright. Told you we only have 3 slides left. But I will take those and I will condense them and print them